Imagine you're rushed into the emergency room with this crushing, just severe chest pain, like an elephant that's sitting on your ribs.
Right, yeah.
Yeah.
The classic symptom. And the doctors and nurses, they immediately start swirling around your bed.
Exactly. They are moving incredibly fast, but they aren't panicking, And they certainly aren't just going by their gut.
No, definitely not. Every single order they bark out is backed by this incredibly precise, data-driven web of frameworks to calculate your exact odds of survival.
Right. And they use that math to essentially dictate every single step of your recovery. So welcome to the deep dive.
Thanks. I'm excited to get into this one.
Yeah, today we are looking at a massive, highly detailed set of sources. It's a complete clinical decision support framework for risk stratification and management in acute MI. And just to clear the medical jargon right at the top, an acute MI or myocardial infarction is a heart attack.
Right. And our mission today is to really demystify exactly what happens behind the scenes in a hospital during one of these events. I mean, we're going to trace a patient's journey from that very first terrifying heart monitor reading all the way to the moment they are finally cleared to go home.
Which is a long journey, honestly.
It is. And what's fascinating here is how medical professionals have to synthesize just massive amounts of data, constantly shifting between observing physical symptoms at the bedside and then relying on these complex digital algorithms.
All in real time keep you alive. Okay, so let's unpack this. We have to start at minute 0. You're in the hospital bed, and the very first thing they do is stick those little adhesive patches all over your chest, right? Hook you up to a 12-lead ECG.
Yeah, the ECG.
According to the framework, this gives the doctors the very first definitive baseline for mortality risk. But what are they actually seeing on that screen?
Well, they're looking at the electrical map of your heart.
Yeah.
Because, before they can treat the physical muscle, they have to see how the electrical circuitry is firing.
Makes sense.
Right. So our sources break this initial reading into 3 distinct tiers of baseline risk. Let's start with the absolute most severe scenario, which they categorize as extreme risk.
Okay, the worst case scenario.
Yeah. This is identified on the monitor as an extensive anterior MI, meaning a massive heart attack on the front wall of the heart, combined with something called a fascicular block.
Wait, let's not just drop fascicular block without breaking it down a little. That sounds like the electrical wiring itself is physically severed or something.
It is exactly what it means.
Yeah.
And it's why this category is so lethal. The anterior wall of the heart is your main pumping chamber. So if you have an extensive anterior MI, a huge chunk of your main pump is dying because of a blocked artery.
Wow. Okay.
But the fascicular block means the actual electrical cables that tell the rest of the heart muscle to beat to sort of compensate for that damage, they are also cut off. The signal just cannot get through.
That's terrifying.
It is. When a doctor sees this specific devastating combination of, muscle death and electrical failure on the ECG, the patient faces a 20% 30-day mortality rate and a 25% 1-year mortality rate.
Oh my gosh, 1 in 4 of these patients won't survive the year.
Right.
That is just a staggering statistic to process just from looking at, squiggly lines on a screen. So if that's the extreme risk, what's the next tier down?
That brings us to high risk.
Yeah.
So this is the exact same extensive anterior MI, that massive damage to the front wall of the heart, but without the fascicular block.
Okay, so the muscle is dying, but the electrical pathways are still miraculously holding on. Like they're trying to send signals.
Exactly. Because the circuitry is intact, the mortality risk drops, but it's still very serious. It's a 10% 30-day mortality rate and the 20% 1-year mortality rate.
Got it. And the final category on the ECG.
That's moderate risk. This involved a heart attack in the inferior or lower territories of the heart. So the anterior wall is safe. For these patients, the 30-day mortality drops significantly, down to between 5 and 10%, and it's a 10 to 12% 1-year mortality.
Okay, here's where it gets really interesting to me, though. The ECG gives them this incredibly fast, brutal breakdown of the odds, but it only tells the doctors about the electrical circuits.
Right.
It doesn't tell them anything about the actual human being lying in the bed. I mean, you could have a 40-year-old marathon runner or an 85-year-old heavy smoker showing the exact same electrical problem, but their actual chances of surviving are going to be wildly different.
You're totally right. If we connect this to the bigger picture, the electrical data means very little without the clinical context. And that is where the TMI scoring system comes into play.
The TMI score.
Yeah. TMI quantifies the mortality risk by evaluating 3 distinct clinical domains. Those are history, physical exam, and presentation.
Right, and the framework details some very specific point values here. And looking at them, they aren't just arbitrary numbers, are they? They are directly tied to how much reserve the body has left to fight.
Exactly.
Like, let's look at the history inputs. Age plays a massive role. If you are over 75 years old, that immediately adds 3 points to your score.
Precisely. Because, at 75, your physiological reserve is naturally lower, your vessels are stiffer, your organs have less bounce back.
Makes sense.
Yeah, and if you're between 65 and 74, it's 2 points. And having a history of diabetes, hypertension, or angina adds 1 point, because those conditions mean your vascular system is already compromised before the heart attack even started.
And then the physical exam inputs really paint a picture of mechanical failure. Like if your systolic blood pressure drops below 100, that adds another 3 points. I'm assuming that means the heart is literally failing to create enough pressure to push blood through the pipes.
That is exactly the mechanism. Blood pressure isn't just a number. It's the force keeping your organs alive.
Right.
So if it drops below 100, the pump is failing right in front of the doctor.
Wow.
Conversely, if the heart rate is over 100 beats per minute, that is 2 points. because the heart is frantically beating faster and faster to try to compensate for the lack of pumping power,
Right.
which, just exhausts the dying muscle even faster.
It's like a vicious cycle. And finally, under presentation inputs, they look at how long the heart has been suffocating. If the time to treatment takes longer than 4 hours, that adds a point.
Right, because time is muscle. Every minute that artery is blocked, more heart tissue permanently dies. All of these points feed into what the framework visualizes as a risk thermometer.
And it scales incredibly fast, right? Like if your score is a 0 or a 1, you are at the bottom of the thermometer under a 2% mortality risk.
Yeah.
But if those variables compound and you score greater than a 9, that thermometer spikes into the red and the mortality risk skyrockets to over 35%.
It's dramatic.
Let me try to frame this with an analogy for the listener. The ECG monitor is kind of like looking at a satellite image of a forest fire. It tells you exactly where the fire is and how big the burn radius is.
Okay, I like that.
But the Theme-1 score is like actually standing on the ground inside the forest. You are checking to see if the forest is full of dry, dead brush like a history of diabetes, and you are feeling how fast the wind is blowing, which is the heart rate and blood pressure. You really need both to know if the entire forest is going to burn down.
That is a brilliant way to conceptualize it. The terrain matters just as much as the initial spark, and these are rapid, vital inputs. A trained physician is calculating that thermometer in their head in real time while they are assessing you.
Okay, so the immediate survival odds are calculated. The doctors know what they're up against, but now they need to assess the physical damage to the heart's actual pumping ability right in that moment, right? We're moving from calculating baselines to immediate physical action.
Yes, this brings us to the Killip classification. This dictates your immediate hemodynamic priority.
Hemodynamic.
Yeah, hemodynamic simply refers to the physical dynamics of blood flow. Is the pump moving the fluid effectively, or is the fluid backing up? The framework calls this the Killip escalator, and it breaks down into 4 classes based entirely on physical bedside observations.
Okay, so class 1 is the best case scenario. There's no physical evidence of congestive heart failure. The blood is moving normally. The mortality rate here is around 5%.
But then you step up to class 2. Here, the doctor is using their stethoscope to listen to your lungs and your heart. They're listening for an S3 gallop, which is this abnormal third heartbeat sound.
It literally sounds like a galloping horse, doesn't it?
It does. It happens when blood sloshes into an overfilled, stiff heart chamber. They might also hear rails in the lungs, which is a crackling sound. It means fluid is just starting to leak into the air sacs because the heart isn't pumping it forward fast enough.
And the mortality jumps to 14%. That brings us to class 3. And the way the sources describe this is genuinely terrifying. They call it frank, flash pulmonary edema. What is physically happening to the patient here?
The patient is essentially drowning in their own fluid. The left side of the heart has failed so badly that all the blood returning from the lungs hits a traffic jam. The pressure builds up so high that fluid is forced out of the blood vessels and rapidly floods the lungs.
Oh man, so they're gasping for air.
Yes. However, in class 3, their blood pressure is still over 100, meaning the pump hasn't completely given up yet. But the mortality rate at this stage is 32%.
Which leads to the absolute bottom of the escalator, class 4.
Yes. Class 4 is cardiogenic shock. This is total system failure. The pump has fundamentally failed. It cannot generate enough pressure to feed the brain, the kidneys, or the liver.
The organs are just actively starving for oxygen.
Exactly. This dictates the absolute highest priority for medical intervention, and it carries a massive 57% mortality rate.
Wow. So what does this all mean? The doctor is standing at the bedside, listening for a galloping heartbeat, looking for fluid in the lungs, feeling the pulse. It is incredibly physical, observable medicine.
Very hands-on.
But here's the thing that jumped out at me from our sources. To figure out the patient's long-term prognosis, whether they'll survive the next 6 months, the doctors have to completely abandon that physical exam and switch to digital tech.
Yeah, this raises an important point about the limits of human calculation. While Killip handles the immediate crisis, the drowning lungs and the crashing blood pressure, it doesn't tell us how the body will tolerate the recovery.
Right.
That brings us to the GRACE ACS risk model. GRACE provides a holistic prognosis for both in-hospital and 6-month post-discharge mortality.
But I need to push back on this a little because the framework explicitly states something wild. It says the GRACE score cannot be calculated manually at the bedside. The math is literally too complicated for a doctor to do in their head. They have to pull out an app or use a web interface. Are we really outsourcing doctoring to smartphones?
Well, I wouldn't say we're outsourcing the doctoring. We are augmenting it. The GRACE model synthesizes biochemical data that is deeply weighted and nonlinear.
Give me an example.
Sure. For example, it looks at your serum creatinine levels. Creatinine is a waste product filtered by the kidneys. Why do we care about the kidneys during a heart attack? Because the kidneys are incredibly sensitive to blood flow. If they aren't filtering creatinine, it means the heart isn't pumping blood to them effectively.
Ah, so it's like a biochemical warning light for the pump.
Exactly, yeah. The GRACE app cross-references that precise decimal of kidney function against the exact level of cardiac biomarkers in your blood.
Which measure the microscopic muscle death.
Right, along with your age, your heart rate, and the ST deviation on the monitor. A human brain just cannot accurately weigh a dozen interacting variables on a sliding scale in a split second. The smartphone gives the doctor a biochemical microscope to essentially see the future of the patient's recovery.
Okay, so the immediate crisis in the ER is managed. The algorithms have set the prognosis. The patient is alive. Now, how does the hospital plan for long-term survival? Because according to the framework, everything hinges on one single critical measurement moving forward, right? The LVEF.
Left ventricular ejection fraction,
Yeah.
yes. This is the absolute dictator of recovery. Your left ventricle is the main chamber that blasts oxygen-rich blood out to the rest of your body.
The main engine.
Exactly. The LVEF is simply the percentage of blood that chamber manages to squeeze out with each contraction. A healthy heart squeezes out over 50% of its volume. This single percentage strictly dictates the post-MI stabilization pathways.
And the framework breaks this into 3 risk categories. Low risk means the LVEF is greater than or equal to 51%. That's considered preserved function. The muscle survived. They get standard prevention and routine monitoring.
Next is intermediate risk, which is an LVEF between 36 and 50%. Our sources actually subdivide this. If you are between 41 and 50%, you have mild damage. But if you fall into the 36 to 40% range, you are at a very high risk for the heart to progressively weaken and develop dangerous arrhythmias.
But things get incredibly aggressive when someone hits that final category, don't they? The very high-risk group, where the LVEF drops to 35% or lower. The framework calls this profoundly reduced function. The pump is barely squeezing.
Yeah, when a patient hits that 35% threshold, it triggers the immediate initiation of what they call quad therapy. This is a heavy-hitting combination of 4 specific classes of drugs designed to literally force the heart to remodel and survive.
Now, the sources list the acronyms for these drugs: an ARNI, a beta blocker, an MRA, and an SGLT2 inhibitor. But, let's not just read a chemistry textbook to the listener. How are these 4 drugs actually working together to fix a broken pump?
Let's break down the mechanics. Think of the damaged heart as an exhausted, overworked engine. First, you give a beta blocker. This blocks adrenaline. It forcefully slows the heart rate down and lowers the blood pressure.
So it's essentially putting a governor on the engine so it doesn't overheat and destroy itself.
That's exactly it.
Okay, so the engine is slowed down. What about the ARNI?
The ARNI physically relaxes and opens up the blood vessels throughout the entire body. If the blood vessels are relaxed, the weakened heart doesn't have to push nearly as hard to get the blood through. It's like taking a heavy backpack off someone who's trying to climb a steep hill.
Oh, that makes total sense. Then we have the MRA.
Right. After a heart attack, the body's natural response is to form scar tissue. But too much scar tissue makes the heart stiff, like a dried-out sponge, which just causes more failure. The MRA blocks the specific hormones that drive that toxic scarring process. It keeps the muscle pliable.
And finally, the SGLT2 inhibitor.
Which was originally a diabetes drug, actually. But we found it works miracles for heart failure. It forces the kidneys to dump excess sugar and sodium into the urine, which drags excess fluid out of the body with it. It basically drains the swamp, reducing the total volume of fluid the broken heart has to pump.
Man, so it's not just a construction crew throwing pills at a wall. It is a highly coordinated pit crew modifying a damaged engine while it's still running. They are slowing the motor down, widening the exhaust pipes, preventing the metal from rusting, and draining the excess oil.
It's a fantastic analogy. But because this cocktail fundamentally alters blood pressure, kidney function, and potassium levels, the doctors have to monitor the patient constantly for severe side effects like acute kidney injury.
The framework also mentions that having an LVEF under 35% mandates strict ICD blanking periods.
Yeah.
An ICD is an implantable defibrillator, right? A little device in the chest that shocks the heart if it suddenly stops.
Yes.
So why is there a blanking period? Why wouldn't you just implant that life-saving device immediately?
Because right after a massive heart attack, the heart tissue is incredibly inflamed, angry, and electrically unstable. If you put a defibrillator in immediately, it might shock the patient unnecessarily, which is agonizing and dangerous.
Oh, wow.
Furthermore, with that quad therapy pit crew working, the heart might actually heal and improve its function over time. You have to honor a mandatory waiting time, a blanking period, to see what the heart can actually do on its own.
And the rules are strict. If you were just managing it with drugs, you have to wait at least 40 days. But if the patient had surgical intervention like stenting or an open heart bypass, you have to wait at least 90 days before you can assess if they permanently need that defibrillator.
Exactly. It requires immense patience. But while the doctors are waiting out those 40 to 90 days, they also have to navigate another incredibly delicate framework regarding the patient's blood thinners. This is called DAPT, or dual antiplatelet therapy.
Right. The default duration for a patient to be on these heavy blood thinners is 12 months. But the framework emphasizes balancing what it calls competitive ischemic and bleeding profiles. This is where the decisions get really dangerous.
It is a constant tug of war. Let's look at the ischemic modifiers first. Ischemic refers to the risk of a new blood clot forming. Let's say the doctor put a long metal stent into the patient's artery to keep it open.
Okay.
Well, the body hates foreign metal. It wants to form a clot over it. If a patient has a high DAPT score due to things like diabetes or previous heart attacks, their blood is highly prone to clotting. To prevent a catastrophic new blockage, the doctors will want to extend those blood thinners well beyond the 12-month default.
But on the other side of the scale, you have bleeding modifiers. The blood thinners might prevent a clot in the heart, but they also stop the blood from clotting anywhere else.
Yes.
If the patient has a high bleeding risk, which they calculate using scores like ARC-HBR, the strategy completely flips, right? Because a tiny, normally harmless bleeding vessel in the brain could suddenly become a fatal hemorrhage.
Precisely. If the bleeding risk is too high, the doctors have to drastically shorten the therapy to just 1 to 3 months, transitioning them to a single, milder drug.
That is like walking a tightrope across a canyon while holding weights. You are balancing the risk of a fatal blood clot in your heart on your left against the risk of a fatal internal bleed in your brain on your right. Tipping too far in either direction is catastrophic.
It's a highly precarious balance. And that is exactly why the frameworks are so deeply quantified. They take the guesswork out of the tightrope walk.
So let's say our patient makes it through. The immediate crisis is over, they are stabilized on their customized quad therapy, they survived the blood thinner tightrope, and they are finally ready to think about going home. But according to our sources, the hospital has one final massive safety gauntlet to run before letting them out the door.
Absolutely. Before any discharge, the medical team systematically hunts for high-yield diagnostic red flags. They look across 3 distinct categories. First, clinical and hemodynamic flags. For instance, if you have recurrent spontaneous ischemia, which means your chest pain is coming back even while you are just resting in bed, that means the artery is closing again. You aren't going anywhere.
Second are the electrical red flags. The sources mention sustained VP or VF past the 48-hour mark. VT and VF are ventricular tachycardia and fibrillation, basically dangerous, chaotic quivering of the heart muscle instead of a steady beat.
Right.
If that is happening 2 days later, it means there is a deep structural short circuit in the heart, not just the initial shock of the attack.
And the third category involves echocardiographic and structural red flags. These are mechanical nightmares. One of the most critical is a left ventricular thrombus. This is literally a massive blood clot sitting stagnant inside the main pumping chamber of the heart.
Oh, wow.
Yeah, if they spot that on the ultrasound, the patient cannot leave. It mandates 3 to 6 months of systemic anticoagulation because if that clot gets pumped out into the body, it goes straight to the brain and causes a massive stroke.
So if the patient clears all those terrifying red flags, they finally arrive at the ultimate discharge readiness checklist. The framework uses the acronym Post-MI SAFE. Now, we aren't going to read this like a textbook letter by letter, but looking at the categories, it is basically a comprehensive proof of work, isn't it?
That is exactly how to view it. It forces the medical team to systematically prove they have checked every single vulnerability we just spent this entire deep dive discussing. It groups into 3 main safety nets. First, mechanical and structural. They must validate the LVEF pump function, check the Killip class again, and ensure there is no hidden scar burden or ruptures.
Okay, so that's the structural net. Second is the electrical and telemetry net. They review the rhythm strips to ensure no late-stage arrhythmias are hiding, and they formally document those 40-day or 90-day blanking periods, right? So the patient's eventual defibrillator assessment doesn't fall through the cracks.
Spot on. And finally, the pharmacological net. They must prove they optimize the antithrombotic blood thinners by checking those bleeding scores and confirm the quad therapy has been properly initiated without destroying the patient's kidneys. Only when every single one of those nets is secure, checked, and documented can the patient walk out the door.
It is the ultimate failsafe. It ensures that the transition from a chaotic life-or-death ER crisis to long-term outpatient survival is completely seamless.
It really is.
We have been on quite a journey today. We started with the physical jagged lines on a 12-lead ECG, mapping out the devastating electrical reality of a fascicular block. We watched doctors use their stethoscopes to judge the fluid backing up in the lungs, and then pivot to smartphones to process massive biochemical equations with the GRACE model.
Yeah, quite the shift.
We explored how 4 distinct drugs act as a pit crew for a damaged heart, walked the bleeding and clotting tightrope, and finally ran the gauntlet of the post-MI SAFE checklist.
It is a